So remember, T3 and T4 is going to be low. Okay, and TSH is going to be high. So I always start off with T3 and T4. So when it says hypo, I know hypo means low. So when I'm talking about hypothyroidism, I would always say T3 and T4 is low, and the opposite of that, TSH is going to be high. Now, T3 and T4, on the other hand, in hyperthyroidism is going to be high, and the TSH is low. So always think in opposites here. Okay, and remember, with thyroid, the thyroid gland is located in the neck region. Okay, the thyroid gland is very important in controlling things such as your metabolism, your blood pressure, your heart rate, your GI tract. So it's really a multifunctional gland, and of course we need the thyroid gland to be able to survive because it controls so many different aspects within your body. And of course, on the thyroid glands, I think we had a question that we did last time. We have the parathyroid glands located, which if you guys, let me see if you guys remember, what do the parathyroid glands regulate? Do you remember? What do the parathyroid glands regulate?
Calcium.
Perfect. Yes, calcium, and what else? There's one more.
Phosphorus.
Phosphorus. Perfect. Yes, it regulates the calcium and phosphorus, right? So the thyroid gland, of course, is going to be controlling the metabolism, etc. So when you look at the thyroid gland, remember, thyroid gland works on what they call a negative feedback loop, is what they call, which means that the thyroid gland is going to be releasing this T3 and T4. And once it gets to a point where there's enough T3 and T4, it kind of gives that message back to the brain, and then the brain sort of stops releasing TSH. Okay, that's how it works. Now, if my T3 and T4 is low, the brain's never going to get the message that this is enough, because the thyroid gland itself is very understimulated. It's not producing a lot of T3 and T4, and so the TSH continues to be sort of this. It's going to be released. It's going to continue being released with the TSH. So the TSH continues stimulating your thyroid gland, but you don't have any more release of T3 or T4 because it's just not producing enough. So actually, you can see a goiter develop in actually both conditions too, just FYI. It's more likely in hyperthyroidism that you have a goiter, which is sort of that, you can see it on their neck, this kind of bulge. But it's still likely in hypothyroidism too, because their TSH will stimulate it. So it starts getting a little bigger, the thyroid gland. So you do see the formation of a goiter there as well, right? Now let's talk about some causes of why somebody would end up having hypothyroidism, right? You guys, can you throw me some causes out? Throw some things out that you remember that could be potential causes. And you can pull from here too. It's right on the screen. Okay, maybe Annie, can you throw some causes out there for hypothyroidism for me?
Iodine deficiency.
Iodine deficiency, yeah. Okay. So if you're not getting enough iodine, now a lot of the food in the US is fortified with iron, so it's already added in there, but there are, nations out there or people out there that still maybe in the US or maybe even more so probably in more developing nations, you might see that they still have iodine deficiency. So that is a mineral that is needed to produce a thyroid hormone. So if I don't have enough of it, I cannot produce the T3 and T4. The other big cause I need you to remember is Hashimoto's, okay, thyroiditis. And this is an autoimmune condition where when you hear autoimmune, think your own body is attacking your own cells. So your own immune system is attacking the thyroid gland we don't know why. It's an autoimmune condition, and that could end up destroying the thyroid gland. So if the thyroid gland is destroyed, obviously I cannot release enough of the T3 and T4. Okay, now based on what I said, so if I have low T3 and T4, what symptoms am I going to see with people that have hypothyroidism? Maybe Miss Gilda, what symptoms am I going to have? Throw some symptoms out there if I'm having hypothyroidism. Anybody can jump in at this point. What symptoms might I have?
Is it constipation?
Constipation, very good, excellent. Yes, constipation. So I want you guys to just think everything becomes low and slow. Okay, so you're gonna start gaining a lot of weight. Okay, patients can generally become very mood-wise, very depressed. Okay, metabolism is gonna slow down, and you will experience constipation. Your GI tract slows down. You also become very intolerant to cold. Okay, you get very cold easily on a hot summer sunny day. This person's wearing a winter jacket. Okay, hair becomes really fragile. Okay, you start developing a lower heart rate as well, and you have a low urine output. So as you can see, everything is low and slow. Okay, move like a sloth. Okay, think about how sloths move. They're very slow. Right now, what are you going to do to this? So of course, we know a lot of our patients can be on a medication called, what is the name of that medication that they're on if they have low thyroid, hypothyroidism?
Levothyroxine.
Levothyroxine, yes, okay. They can be on levothyroxine, right? Now, there is a solution called Lugol solution that we can give them if they are deficient in iodine. Okay, so if it's specifically iodine deficiency, we can give them a solution called Lugol's solution, right? Now, complications. What happens if this does not get treated? If I just let it go, don't take my meds, and don't do anything? Well, you can go into what they call a mixed edema coma. I always think about it. Okay, you become so low and slow that you become so sleepy that you fall into a coma. All right. Now, when you have mixed edema coma, what are some signs and symptoms that you're going to have? Okay, remember, everything is going to go down. So you're going to experience a low blood pressure, low heart rate, low respiratory rate, and low body temperature. So just think about all your main vital signs are whoosh, they're dropped down. On top of that, you start developing this facial puffiness as well. Right now, on the opposite of that, we go into hyperthyroidism. When hyperthyroidism, remember T3, T4 is high, TSH is low. All right. So think about signs and symptoms is the opposite of what you would see in hypothyroidism. Okay. So in hyper, I'm going to be tachycardic. Okay. I'm going to also have weight loss. So this patient's going to experience a lot of anorexia. So they're going to lose weight, even if they're eating normally. Okay. They're going to be heat intolerant. Okay. Cold winter day, they're walking around wearing a bikini. They're too hot. Okay. That might be a little too far-fetched, but I'm just giving you very extreme examples. Diaphoresis, they're sweating a lot. Nervousness and tremors is a very good. Remember, they're so anxious, and these individuals are very anxious. Anxiety. Remember, the other one was depressed. Now, the cause of hyperthyroidism usually is something called Graves' disease. Okay. In Graves' disease, remember, this is again an autoimmune condition. And especially if they have Graves' disease, you will notice they have a specific symptom called exophthalmos. It's where those eyeballs look like they're like bulging out. Okay. Bulging eyeballs. So I remember one time, I think many years ago, when I went to the doctor, I have bigger eyes, and I think it might be because I have been wearing also very heavy prescription glasses since I was really young. The doctor was like, "Oh, you know what? Your eyes are like really popping out." Uh, so he had me do a test for hyperthyroidism, and no, there was nothing wrong. I mean, I could tell there was nothing wrong because I didn't have any symptoms. And again, sometimes you might have very mild symptoms, but I didn't have any symptoms of this, and I was like, hmm. And anyway, I did just to get the test done too, but it was so funny because I think my bulging eyeballs kind of threw him off a little bit. But that's Graves' disease. Okay, so Graves' disease can be a cause, right? And specifically with Graves' disease, I always think about it as this person's going to be so Graves' disease, remember, is an autoimmune condition. This person's going to be so high, like everything is so high that they're going to end up running to the grave. Okay, I know it's a horrible way to think about it, but that's the way that I remember it. Okay, now you think about the medications that they can take. Remember, there's two: propylthiouracil and methimazole. So we did have a question about this. So if I have propylthiouracil and methimazole, which one do I give during the first trimester of pregnancy, and which one do I give in the second and third? Anybody remember? Which one is the first preferred in the first trimester? If this is a pregnant woman. How about Shirley? Do you remember?
No, I have to check.
No worries. Anybody else? Which one do we get in the first trimester?
Methimazole.
Nope, the PTU. Okay, PTU is the drug of choice in the first trimester. We do not give methimazole. Okay, so first trimester we give PTU. Second and third trimester we can switch them over to methimazole because methimazole in the first trimester can cause congenital deformities. But good guess, right? All right, now complications of what happens if we don't get hyperthyroidism treated. We can go into what they call a thyroid storm or thyrotoxicosis. Okay, that's known as. And remember, everything is going to go up. So the opposite of myxedema coma, high blood pressure, hyperthermia, tachycardia, tachypnea, everything is up. All right. Okay, ladies, any questions on the thyroid? One. Nothing. Okay. Perfect. All right. So I'm going to give you guys some questions. And this is going to be related to the next topic that we'll talk about. So a male client is treated for the syndrome of inappropriate antidiuretic hormone, SIADH. Which nursing intervention is appropriate for this patient? Okay. Okay. You can just say the answer out loud.
C.
C, restricting fluids. Yes. And why do we restrict fluids? What's the rationale, please?
Water retention too much.
Water retention too much in SIH. Perfect. Okay. So this one, a female client has a serum calcium level of 7.2 milligrams. During the physical examination, nurse Noah expects to assess what?
A.
Trousseau sign. Yes, this is a sign of hypocalcemia. And how do we assess for the Trousseau sign? What do we do? How do I check for the Trousseau sign? Remember blood pressure cuff on the upper arm? You pump it all the way up and you watch for what they call carpopedal spasms of the hand. So the hand going like this. Okay. What's the other sign that we also check for?
Jovac.
Yeah, Chauvastex. And Chauvastex, remember, I always think CH for chin. You tap the chin and they're going to start twitching like that. Okay. So watching for the twitch. All right. Oops. Okay. When taking a health history, oops, oh my gosh, when taking the health history, the nurse screens for manifestations suggestive of diabetes type 1. Which of the following manifestations are considered the primary manifestations of diabetes type 1 and would be most suggestive of diabetes type 1 and require follow-up investigation? Okay, so remember, they're talking about type 1 diabetics. Okay, anybody? About Annie.
Requires follow-up, right?
Yes.
Is it B?
C.
Neither B nor C. It's actually D.
D.
D for
My
dog.
second
Okay.
answer is D.
Yeah.
I'm torn between D and U.
Yeah, so D for dog. So this is a tricky answer because they give you a lot of things to talk about in the beginning. Like they'll give you a lot of context clues. But they are looking for the simplest answer. Basically, they're looking for, remember, polydipsia, thirst, okay? And therefore they're taking in a lot of fluids because they're very thirsty, and then polyphagia, and then there's the polyuria part, which it's not in there, but they basically have a lot of hunger, polyphagia, polydipsia, okay? They're taking a lot of fluids, and this is suggestive of type 1 diabetes. Okay. The other ones are complications, guys. They're not suggestive of symptoms. So here's the kind of the key word. Which of the following manifestations are considered the primary manifestations? So when they're talking about manifestations, they're talking about symptoms. So the other things that they're talking about, for example, B, poor circulation, wound healing, and leg ulcers, these are considered to be complications, not manifestations. Okay. Of course, lack of energy, weight gain, and depression, probably not recommend type 2. Remember, this is type 1. If you notice, most type 1 diabetics are very skinny, okay? Remember, type 1 diabetics, your body does not produce any of its own insulin. The pancreas does not produce any of its own insulin, so very little insulin, and they're born with it, okay? And they have to get insulin for life. In type 2 diabetes is usually diet related, and that's where you would see that the individual is heavier. They don't necessarily need insulin. They can start off with like metformin or medications that they take by mouth. But as the diabetes gets worse, and if it's not controlled, of course, eventually they're going to need insulin as well. So this is more indicative of maybe type 2, not type 1. And excessive intake of calories, rapid weight gain, difficulty losing weight, again, could be indicative of type 2 diabetes, not type 1. So the answer would then lead to D, an increase in 3 areas. Okay. So really quickly, I know we have gone over diabetes multiple times. So I'm going to kind of have you guys we'll do like a brainstorming session here. So type 1 diabetes, I just explained, mostly genetic. Juvenile diabetes is another way that they describe this as well. Because again, you have adolescents who are also diabetic at this point. And we're thinking about things like
Insulin resistance.
Oh, I'm sorry. Did you say something? Oh. So signs and symptoms we already mentioned: polyuria, polydipsia, polyphagia. Okay. What is the complication of type 1 diabetes? What's the complication? DKA, diabetic ketoacidosis. Okay, diabetic ketoacidosis. And what symptoms am I going to see if I have diabetic ketoacidosis?
Fruity breath.
Say that one more time.
Fruity breath.
Fruity breath. Okay, fruity acetone breath. Okay, perfect.
Mm-hmm.
Okay, what else? And you guys should all know DKA by this point. Let's throw some things out there. What kind of respirations am I having?
Usmo.
Guzman's respirations. Very good. And how do they look like? Rapid and deep breathing. Okay, what else? What about GI related? Give me something GI related. Nausea and vomiting. Okay. Okay, give me something urinary related.
Proteinuria.
Not necessarily protein. What's going to be in there? Not protein. Ketones.
Yeah. Yes. Okay.
Ketones. So ketonuria. Very good. Okay. And remember, ketones are produced because, looking back at patho, is that your body, because a person goes into DKA because they're not taking their insulin. Remember, DKA happens when your blood sugar is greater than 250 in type 1 diabetics. If you do not become compliant with your insulin, your body then cannot use the sugar, okay, because you don't have the insulin. Remember, the insulin is the key that opens the lock. And so the sugar cannot get into the cells. So your body says, okay, what can I use for energy? So they start breaking down fat. When fat breaks down, you have the production of ketones, which then leads to a lot of ketones building up within the urine. Okay. Now, you of course can have nausea, vomiting, abdominal pain. What about the fruity acetone breath we mentioned? Are you going to see confusion and altered mental status? Yes. Okay. So you will see that it starts affecting their mental status as well, and probably they are starting to have a lot of fatigue and tiredness. Okay. How do we treat DK? What are some treatments? What do we do when they get to the hospital? This patient's in DK. What do you do? You're the nurse. What do you do? The doctor's going to order IV fluids. Very good. IV fluids is for hydration. Okay. You want to hydrate. You want to dilute the ketones. Okay. Because there's a lot to build up, and you want to dilute the excessive sugar. So the goal is to dilute and hydrate. Okay. What's next? What else are you going to do? Guys, their blood sugar is greater than 250. So what are you going to give them?
Insulin.
What type of insulin? Regular insulin. Remember, regular insulin is the only one that you can give IV. So you're going to give them regular insulin IV. All right. What else are we going to monitor? So when you're giving insulin IV, it causes something. It does what to the potassium level? When you give insulin IV. What happens to the potassium as a side effect of regular insulin being received IV form? Guys, think about
potassium.
Potassium decreases. Very good.
Yes.
Yeah, potassium decreases, so you're going to have to monitor potassium levels. Yes, hypokalemia, and maybe replace potassium if need be. Okay, very good. So kind of this is a multi-layer question. These are some of the questions that you might see where you have to build on things that you see. All right. And then you're also going to be monitoring your ABGs, right? Because of what? Why am I monitoring the ABGs? Because I have too much of what? Too much of the ketones, because ketones will make the blood. What do they make the blood? Acidic or alkalotic? Guys, it's right in the word.
Acidic.
Acidic. Acidosis. So I'm watching out for metabolic acidosis when I have a DK. Okay. All right. And then, of course, because I'm giving them an insulin, I want to make sure I'm monitoring for hypoglycemia, etc. All right. Any questions on type 1 diabetes DK? Nothing. Okay, let's do type 2. So type 2, I already mentioned all the kind of the risk factors: diet, lifestyle, exercise, obesity, genetics, all of the contributing factors. Okay. If type 2 diabetes doesn't get treated, one of the complications that we can have, and these are long-term complications. What are some long-term complications of type 2 diabetes not getting controlled? Say this patient doesn't take medications. What are some long-term complications? We had it in one of the questions that we mentioned. Think about some of the patients or maybe family members that you have. Maybe they have diabetes. What do you see if their blood sugar isn't controlled? They're high risk for strokes, because high sugar, think about sugar as a sticky substance that destroys and damages the blood vessels. High risk for cardiovascular disease, okay, such as heart disease. Okay, do you think your wound healing, if they have a wound, is it going to take a really long time to heal?
Yes.
Yes, so poor wound healing. Okay, think about this patient maybe having what else? What about nerve damage, right? So long-term complications, neuropathy. Remember, the blood sugars, the sticky sugar damages the nerves. So retinopathy. Why do you think a lot of diabetic patients have issues with vision? Because it damages the nerves and the blood vessels to the eyes. So they tend to have poor vision. This is one of the reasons why we encourage frequent or annual visits for checking eye vision for people that are diabetics. Okay. And do you think they're more likely to also have peripheral arterial disease or not really? Would they experience peripheral arterial disease?
Yes.
Yes, because the sugar damages the arteries that are going to the arms and legs. Okay, mostly the legs. All right. Do you think diabetes will damage your kidneys or not really?
Yes.
Yes,
Yes.
so it leads to diabetic nephropathy. And this is the reason why a lot of our patients are on what? Over time. It damages their kidneys so bad that they end up becoming, what is a procedure where we filter the blood?
Dialysis.
Dialysis.
Dialysis. So they end up going on dialysis, and that could be either peritoneal or hemodialysis that we're talking about. Right? Okay. Now think about if my patient is going to go into an acute condition, such as the opposite of DKA, but we only have it in type 2 is HHNS. Okay. There's a pretty long word. Does anybody remember what this stands for, HHNS?
I only remember one. Is it hyperosmolar?
That's good. Okay, that's actually really good. Most people don't remember that one. So hyperosmolar and hyperosmolar. Anybody remember anything else? It's the second H. Hyperglycemic. N is for non-ketotic syndrome. So everything is right in the word, guys. It says hyperosmolar, which means that you have a lot of, it's very concentrated. Your blood is very concentrated. Your blood sugar is very high. Non-ketotic means that you don't actually produce any ketones. Unlike our type 2 diet, type 1, we don't have any ketones being produced, and it's a syndrome. And for you to have this condition, you need to have a blood sugar greater than 600. Okay, so this blood sugar has to be very high. Okay, say you have this blood sugar. What are some signs and symptoms that I might experience with such high blood sugar? Let's work our way down from head to toe. So brain, would I see confusion or altered mental status?
Altered.
Yes, absolutely. With a blood sugar that high, for sure. Have I seen patients of blood sugar greater than 600? Yes, I have. It's very common. Some of your patients, even in a regular setting, their blood sugar is high as like 450, 500. Yes, very on the borderline. Yes, you will see this. Okay. And there are people that walk around with 400 blood sugar it looks like nothing's wrong with them, because oftentimes what happens, their body get used to it. But if it's greater than 600, boom, bam, you cannot. Okay, you need to double check the blood sugar, number one. Another things that you want to check out also is make sure that they have not eaten when you're taking the blood sugar, because their blood sugar is obviously going to be high, before you kind of do a rapid response, or kind of call the MD and say, hey, we need to do something for this patient. Their blood sugar is very high. I'm sorry, probably won't call rapid response. I take it back, unless their blood, their vitals are sort of dropping. You'll call the MD right away though. Page them right away and say, hey, we need to get the patient's blood sugar down. Okay. All right. So give me some symptoms that you're going to have when they are in this. So altered mental status. Now work our way down. Anything with your thirst? Are you going to be more thirsty, less thirsty? What's going to be happening?
More thirsty.
More thirsty. So very thirsty. Okay. Why? Because you're probably peeing out a lot. They're having polyuria. Remember, classic sign of diabetes, all that sugar is so concentrated, it's going to pull all the water out of the system. When the sugar leaves, water is going to follow with it. Water is very attracted to sugar. So it's going to leave. So you're going to have a lot of polyuria, which means that I'm going to be urinating a lot, but I'm also very thirsty. All right. So if I'm thirsty, think about all the symptoms of me being thirsty. So everything's going to be dry. I probably have a dry mucous membranes. Okay. And the thirst contributes to also my confusion and altered mental status. And if that's not corrected, then I can even go into a coma, okay, if I don't correct this. And And a dry mouth, okay, we know that, weakness, and they would also have fever. Remember, everything, your body temperature is going to go up because you really don't have water to sort of cool it down. So you're going to experience a hyperthermia. Okay. Now, my question to you is, so here's a scenario that I'm going to give you. So say that you have a patient who is exhibiting symptoms such as confusion, altered mental status, fatigue, and they have a fever. Are you going to call rapid response, or are you going to just call the doctor? Think about that. Are you going to call rapid response? Or are you going to do the rapid response in the hospital, or are you going to just call a doctor? If they are having confusion, altered mental status, fatigue, weakness.
I think rapid response.
So call rapid response. Because at this point, and you, of course, you check their blood sugar and it's greater than 600. When they're actively having those symptoms where it's affecting their mental status and confusion, all that, yes, I'm going to call the doc, okay? Because they're actively having, I'm going to call the rapid response because they're actively having these symptoms. So this is a priority patient. This patient you're going to prioritize, especially if they have a lot of confusion and altered mental status going on. If the patient's greater, maybe the patient's blood sugar is greater than 600, but maybe they're not really having any of these symptoms, I can go ahead and just page for the doctor, okay, and then do all the things. But of course, you're not going to delay care, but it varies on what you would do based on the symptoms that this patient is exhibiting, right? Now, how are you going to treat the patient? So let's talk about treatment measures. So what are you going to do first? It's going to be priority for this patient. So based on everything that we talked about, guys, what are some treatment measures? Think about the symptoms that they're having. Fluids. And again, prioritization, guys, you're going to give fluids over insulin first. I have seen many questions, students miss this. Give fluids first because the hydration, the hypovolemia, the low fluid volume is more of a concern than the blood sugar is. So you're going to give hydration first, IV fluids, okay? Then you're going to give them what?
Insulin again.
Insulin. Yes, you're going to give them insulin. And remember, the only insulin you can give IV is?
Regular
insulin.
Mm-hmm.
So regular insulin you're going to give. Okay, what's next? What do you monitor when you're giving them the insulin?
Potassium.
Potassium. Excellent. Okay, and why do we monitor the potassium? What happens? Why are we so concerned about the potassium? Because it affects the what?
The heart.
Kidney.
Yeah, arrhythmias. So it can lead to arrhythmias, okay? And remember, what kind of IV fluid am I going to use? Was it
0.9?
So you're going to start off with 0.9 first, and then you're going to switch to 0.45 because, again, you don't want a lot of fluid retention happening. So you'll start with a large, like a bolus dose. So you're going to give them bolus, meaning you're going to let it run with no, it's not really timed. Sorry, not timed. It's not on a rate. It's on a bolus. So when they say bolus IV fluid, it's like you're just letting it run free. And then they're going to switch to 0.45 as they become more stable, right? Okay, and why? And remember, with the regular insulin, though, we are going to put it on a rate. And the reason we do that is because we want to prevent cerebral edema from happening because of the sugar shifts. It's going to cause a lot of that. Okay, I think that's about it for type 2. All right. Any questions on that? Nothing. Anything? Nothing. Okay. All right. So we will keep on going. Okay, just going to mention some regular things that you might possibly see. Again, these are not high yield, so I'm just going to skim through them. You have another endocrine condition called gigantism. Okay, sounds like a big giant person. And this is where the pituitary gland is going to be producing excessive growth hormones. And usually this occurs before puberty and when the ends, the epiphysis of the long bones are not yet fully closed, okay? By the way, this is how they monitor that you're done growing. How do you know that somebody's done growing? Because the ending of your long bones. So when they talk about long bones, they're typically referring to like your femur bone, okay, which is on your leg. Okay, so these kinds of bones, the epiphyses, the ends of it, when it closes, they can see it on an X-ray. If it's more dense, that means that you basically stop growing. This is how, like, you know, I used to have mild scoliosis, and the doctor, you know, would be monitoring just my spinal curvature, and so they did tell me I think at one point they were like, oh yeah, like you're done growing. And again, I'm very petite. I'm only 5 feet tall, so I was kind of like, oh no, I'm done growing, you know. But that's how they monitor that. So in this condition, you have too much of the growth hormone, excessive. Okay, dwarfism, on the other hand, is where you don't have enough during childhood. And so there's a little woman, dwarfism, you know, kind of pictures there. And then acromegaly is specifically where you have growth hormones, again, over secretion of the pituitary gland, but it affects your arms and your legs, okay, hand, feet, and face. So these individuals, specifically, it's acromegaly, so arms and legs are going to be very long, okay. Their hand and their feet and the face, as well, is going to be affected. So this is where you are specifically focusing on the extremities. Okay, so these are some of the signs. They have a big lower jaw, thick lips and jaws. They can also start, acromegaly affects the internal organs as well. So the heart obviously is more enlarged, and the spleen and the liver. They're going to possibly have ED, erectile dysfunction, and possible joint stiffness, etc. Okay. Right, and how do we do acromegaly? We do an MRI, because when an MRI, we can see the pituitary gland is enlarged. On X-ray, the bones and skull are more thick, and they have elevated growth hormone levels. Okay. How do we manage acromegaly? We can remove the pituitary gland, okay, and they call it a hypophysectomy. Okay. And they might need radiation post-op as well. And then there's medications to decrease growth hormone levels. You guys need to know this part, okay? The medication, such as a parlodel or bromocriptine. Okay, bromocriptine is also used for a Parkinson's medication. Okay, but that can also be used to decrease growth hormone, bromocriptine. So remember that one specifically. And I just want to see if there's a generic. Yeah, that's the brand name. Parlodel is a brand name for bromocriptine. Okay. After the surgery, that's what you need to focus on. If they had a hypophysectomy, which is removal of the pituitary gland, anything that you do, any sort of removal of anything up in your skull, your brain, or eyes, a couple of things that you don't want to do. So, and I've seen a lot of questions about cataract-related things too. So if they have cataract surgery, what not to do. So patients not to bend over, cough, sneeze, or use a straw post-op to prevent dislodging the graft that seals the operative area between the cranium and the nose. So no straws, no coughing, no sneezing, no bending over, no lifting anything heavy, okay, post-surgery. We don't need to know about any of this. This is a rare condition. Okay, we do need to know the difference between your two things, which is your diabetes insipidus and your SIADH, okay? So diabetes insipidus, okay, is going to be when there is a hormone called the antidiuretic hormone is secreted by the pituitary gland, okay? Now, in diabetes insipidus, you don't have enough. You lack antidiuretic hormone. Remember, antidiuretic hormone is secreted by the pituitary gland. It is a natural hormone that is released when your blood pressure drops, okay? When your blood pressure drops, antidiuretic hormone is going to be, when your blood pressure increases, okay? Or I take it back, just to regulate the blood pressure. So if you, in diabetes insipidus, you don't have enough antidiuretic hormone, okay? So if you don't have enough antidiuretic hormone, you're peeing out a large amount of water. And this is the reason why they call it diabetes. It has nothing to do with diabetes, as you can see. It has to do with the fact that they have symptoms related to diabetes, which is they're going to have a lot of thirst, and they're going to be peeing out a lot, okay, which is symptoms of polyuria, polydipsia. All right, so when they have this, remember, low antidiuretic hormone, large amounts of urine that they're peeing out. On the opposite side of this is SIADH, which is where you have too much of this antidiuretic hormone. When you have too much of this antidiuretic hormone, remember, you don't pee out, you retain everything. You're holding on to a lot of water. So you have fluid retention when you have SIADH. Now, talking about all the symptoms that I just mentioned, Okay, in diabetes insipidus or SIADH, which one are you going to do fluid restriction? Which one would you do fluid?
SIADH.
SIADH, okay. In which one would I do sodium restriction?
Diabetes insipidus.
Diabetes insipidus, okay. All right, in which one would I monitor intake and output? Which one would I monitor intake and output?
Is it both?
Both, absolutely both, okay. Which one would I do daily weights?
Both also.
Both, yeah, both, absolutely. Okay. In diabetes insipidus, okay, just to kind of reiterate, okay, these are some of the possible assessment information that I'm seeing. And they like to focus on urine output as well. So urine output is usually normally what? What is the normal urine output? Normal urine output is
30
30
ml.
ml in 24 hours, or sorry, 30 ml per hour,
Mhm.
30 ml per hour. And so 720 mLs in 24 hours is the minimum, right? So in diabetes insipidus, of course, it's going to be higher than that. And they like to focus on the urine specific gravity, which is the concentration of the urine. Is the urine going to be more concentrated or less concentrated in diabetes insipidus? Less. So it's going to be more dilute. Okay. They're going to have weakness. They're going to have dehydration. They're also going to have weight loss. Okay. And thirst is excessive and constant. They can do a test called the fluid deprivation test, where they don't give you any fluid for 5 to 6 hours and then measure the urine volume. So in a fluid deprivation test, what are they going to find? Are they going to find out the patient is still having a large amount of urine if they have diabetes, or less amount, even if they withhold fluids for 5 to 6 hours? What are they going to find? Is the urine volume still going to be high, even if they're withholding fluids? Think about why they're doing that. They're doing the fluid deprivation test, so they want to find out if you actually have diabetes. So they will not give you any fluid for 5 to 6 hours, and they measure the urine volume afterwards. What is the urine volume going to be? Is it going to be high or low?
High.
High. Yes, very good. High, because that's how they identify that this is not, because remember, if I give you fluids, of course you're going to pee out. But if I don't give you any fluids for 5 to 6 hours and you're still peeing on a large amount, that tells me there's something internal going on. Okay, good. What about the urine osmolarity? Is that going to be high or low? Urine osmolarity. Again, looking at the concentration within the urine. Is the urine going to be concentrated or more dilute?
More dilute.
More dilute. What about serum osmolarity in the bloodstream? Opposite. So the serum is going to be more concentrated because I just lost a lot of fluids from my body. So serum is, they're talking about the blood. The blood is going to be more concentrated because I lost a lot of fluid because I'm peeing it out. So these are going to be opposite. Okay. If it's urine osmolarity is going to be a low, serum osmolarity is going to be high. It's going to be more concentrated. Okay. How do we manage it? Well, we can give them what we call antidiuretic hormone, which is specifically called desmopressin. You need to remember that. Desmopressin. Okay, we're going to do sodium restriction. We can also give them diuretics. And this is interesting. Okay, you're thinking, why the heck are you giving them diuretics? They're also losing a lot of fluid. So, and it's not any diuretic that we'll give them. It's only specifically thiazide diuretics that we can give. And thiazide diuretics is used in diabetes insipidus. And I have seen a lot of questions on this where they are using, they actually have the student choose thiazide diuretics as the answer. Because the thiazide diuretics actually directly work on your kidneys, and so what it does is that it actually causes less fluid for excretion in the distal convoluted tubules. So this is the reason why they're using thiazides. Okay, we can also use anti-inflammatory agents such as Indocin. You don't need to specifically know about that; just know the first three. Really, diabetes insipidus. Okay, we push fluids. We monitor urine output every 30 minutes while in therapy, and we monitor vital signs and weight loss. Okay. I'm surprised what happened to my SIADH. Okay. Let me pull up SIADH really quickly here. Okay, we can just do it. So remember signs and symptoms, you have a lot of fluid retention. So if I have a lot of fluid retention, is my heart rate going to be high or low in SIADH?
High.
High. What about blood pressure, high or low?
Low BP.
High BP.
High.
Because remember, I'm holding on to a lot of
Overload.
fluid. Yeah, overload. Overload, blood pressure is going to be high. Okay. Remember, I'm holding on to a lot of water, so my salt level is actually going to be diluted. So, and I'm going to have hyponatremia. Salt is going to be hyponatremic because I'm just over diluted with fluid. Think about this, guys, as more focusing on the fluid and how the fluid level is going to affect everything else. Opposite in diabetes insipidus, I'm going to have not enough fluid, so it's going to look like there's more salt. So I'm going to become hypernatremic, right? Now, urine specific gravity, let's talk about that. Is that going to be high or low in SIADH? Urine specific gravity is going to be high or low?
Low.
It's going to be high. Remember, they're not peeing out. They're retaining everything in
High.
SIADH. Opposite of diabetes. So it's going to be more concentrated.
Okay.
Okay. What about serum osmolarity in SIADH? Concentrated or diluted?
Diluted.
Diluted. Yes. Okay. Remember, opposites. All right. So, and fluid restriction, and you're obviously going to do diuretics for this patient. Fluid restriction and diuretics is going to be your goal. Okay. Yeah. Okay, I think that's pretty much it for SIADH versus diabetes insipidus. Let's take a quick 5-minute break. So we'll meet back at 6:05, or sorry, 6:10 p.m. So let's take a quick 5-minute. All right, ladies, let's get back on. Okay. Oops. This one. Jump all the way down. Okay. Okay, we're going to continue on doing some review questions for the next hour and practice on prioritization, delegation, all those kinds of things. Okay, so right here, I have a question right here. A nurse is caring for a patient after a left-sided cardiac catheterization via femoral artery. Which of the following findings require immediate intervention? So key word there is the immediate. So think airway, breathing, circulation, which one's going to kill them fast?
C.
C, absence of pedal pulse in the left leg. Again, that usually indicates no blood circulation going down there. Very good. Okay, the next one is a medication-related question. A client is taking amiodarone for atrial fibrillation. Which of the following findings should be reported immediately? Mild fatigue, productive cough, and shortness of breath, dry skin, or a low urine output, or yellow
B.
urine. I'm sorry, which one?
B.
B for boy? Yes,
Mhm.
airway, breathing, circulation, productive cough, and shortness of breath. Okay, also talking about amiodarone as a medication, there's some key things that stick out for amiodarone, which is a reason why it's B also. Okay, what is a side effect of taking amiodarone? There's a specific word that I'm looking for.
Is it brutal?
Pulmonary toxicity.
Oh.
So it's actually a pulmonary toxicity. It can happen, which is mean that the lungs are basically going to have the shortness of breath that it can cause by amiodarone related things. And remember, amiodarone is also what we call hepatotoxic. So it can be hard on the liver as well, but really focus on the lungs, right? Okay, a nurse is reviewing a client's medication. Which combination should prompt immediate notification of the healthcare provider? And guys, look out for things that stick out that you always know that causes toxicity, et cetera, et cetera. Okay. And if you know the answer, you can say it out loud. Think about which one can contribute to toxicity. Think about the relationship between each of these two. We've gone through a lot of these medications already, so.
A.
A, very good. Why?
They're both going slow, and then you're draining the water out of it.
Irrational, I like how you're thinking, but it has to do with the potassium. Remember, furosemide causes what?
Hypokalemia.
Hypokalemia, and hypokalemia can increase the risk of?
Arrhythmias.
Hot. Sure.
Yes, but increases the risk of digoxin toxicity.
Okay.
Right.
Yeah, that's the exact rationale. Okay, remember, anytime you have low potassium, increased risk of having digoxin toxicity, so hypokalemia, right? Okay, all right, next one. Okay, client is prescribed atorvastatin. Which patient complaint would require the nurse to contact the provider immediately? Atorvastatin is given for
High cholesterol.
cholesterol, yeah. And what's the biggest thing that we're watching out for?
Headache.
Nope. Remember, it causes something called rhabdomyolysis, which is the biggest side effect.
Oh, C.
C, muscle pain and weakness. Yes. Okay, this is where we need to focus on. I think I mentioned this last time, picked out the major things for medications such as this. Rhabdomyolysis, so muscle pain, weakness. You can also do a lab test called CKMB. okay, which checks for muscle breakdown. So you're going to immediately stop this drug if they're having a lot of that. Okay. All right. This one we already know, super easy. Okay, a patient with hypertension is started on amlodipine. Which of the following side effects should the nurse monitor for?
B.
B, hypoglycemia. Okay. C.
Is it D? C? D?
C. Yeah, peripheral edema. Okay. So remember, this is a calcium channel blocker. So nifedipine, amlodipine, verapamil, diltiazem. Remember, very nice drugs is how we remember this. Very nice drugs. So if they're taking amlodipine, it's going to be a peripheral edema as a side effect. Okay. Peripheral edema as a side effect. No grapefruit juice. Remember that you don't want to give calcium channel blockers to patients that have CHF, congestive heart failure. Bradycardia with rebound hypertension, more common with beta blockers, LOL, ending drugs. You can still have bradycardia and calcium channel blocker, but it's more common with LOL ending drugs. All right. Okay, a patient on warfarin therapy reports dark tarry stools, melena. Which action is most appropriate? What do we think? Which action is most appropriate? I like the participation that I was getting at just a little bit ago. So anybody take a guess? They're on warfarin and they are having melena. What would you do? You are the nurse for this patient. Can't ignore the symptoms, so.
Is it to schedule the next INR test or?
Nope. Remember,
D?
they're D, notify the provider immediately. Yeah, they're reportedly bleeding right now, so you need to do something now. Okay, anytime for any anticoagulants you're seeing bleeding, you need to notify the provider immediately. It is not something that you can wait, okay? So here's the difference between D and B. D says schedule. You only schedule the next INR test if everything is routine, everything is normal. This is not normal. They're having dark tarry stools. It's melena, meaning that they're internally bleeding somewhere. So you do need to notify the provider immediately because the patient probably needs that medication either held or they need to do a stat INR, stat PT-INR. You can't just schedule, right? So it would be D, notify the provider immediately. Very good. We already know too much about nitroglycerin already. Okay, here is somebody who is going to be receiving metoprolol. Okay, the client's vitals are 118/70, heart rate is 52. What is the nurse's best action? What would you do? And this is a very common scenario. What would you do if you were the nurse at this time?
The heart rate is low.
You check blood pressure?
So what do you know about?
Notify the provider.
Yeah, hold the medication and notify the provider. What do you know about LOL ending drugs?
Beta blockers.
Beta blockers, so they decrease both the blood pressure and
Heart rate.
the heart rate, and they're already at the low 50s. And do you want to?
Yeah.
No, you don't want to give them because their heart rate's going to drop down even more. Generally, less than 6. If the heart rate is less than 60, we do not give beta blockers. We hold. Okay, and again, you have to hold the medication and call the provider, and then you will probably monitor the blood pressure after that. And if you're seeing that the blood pressure is going up, there are other medications, you guys, that they can give them. So don't think that, oh, what if their blood pressure is high? Well, they can give them other medications like hydralazine that won't necessarily drop your heart rate down. Okay, So yes, this is something that we do kind of watch out for as well, right? Okay. So let's actually, I just realized I did promise that I would kind of go over psych, which I just kind of was thinking at the same time. So I'm going to give you guys some psych questions. We're going to work through psych and do questions, and then we'll talk about disease conditions that the patient is having. So let me switch over right now. One sec. Yeah, this is going to be based on prioritization questions. So let me switch you over. Okay, do some questions here. All right, so a nurse receives a report on 4 clients. Which client should the nurse assess first? A client with a major depressive disorder, who has not eaten for 2 days, a client with schizophrenia who says the voices are louder today, C, a client with bipolar disorder who has not slept in 72 hours, D, a client taking lithium with nausea, tremors, and diarrhea. Which one are you going to go see first? Right. If you know the answer, you can say it out loud.
I'm looking at B, the word, but I'll go for D as a dog.
Very good.
Because the patient is on lithium and nausea, tremors, and diarrhea.
Excellent. They're talking about lithium toxicity, you guys. Remember, lithium is a medication that is given for. What is lithium given for?
Bipolar.
Bipolar. Okay. And lithium, just like digoxin, is a high toxicity risk drug. And they are having nausea, tremors, and diarrhea, which tells me that they are possibly having lithium toxicity. If this does not get corrected, they can lead to seizures and cardiac dysrhythmias. Here's another tip that I can give you. Anytime you're seeing that they're taking a medication, they're having nausea, vomiting, that is usually a sign of toxicity. Okay, and usually that might be the correct answer in most cases, because the easiest way that your body tries to get rid of anything toxic within your system is to vomit it out. Okay, so early initial signs, nausea, very high risk that this patient is probably having toxicity to something, especially if they're talking about a certain medication. Okay, so after the toxicity page, after this patient, who are you going to go see after them? Who would you see after that, after the toxicity patient? A. Yeah, A, and this is specifically Maslow's hierarchy of needs coming in. Remember Maslow, that pyramid? Okay, you take care of, again, that's something that's urgent, okay? You stabilize the patient, then you think about physiological needs. So food kind of comes into that. So they have not eaten for 2 days. So you want to make sure this patient is getting their hydration in, okay? Another thing that you could probably be doing is, so after that is probably B, because it says the voices are louder today. You want to ask the schizophrenic patient, what are the voices telling you? Okay, because the voices could be telling them to jump off the cliff today. Okay, so if the patient says the voices are louder today, they're not necessarily saying that the voice is saying, I need to jump off the cliff. But that B, again, is not something that you would do first, but it does warrant further investigation. And see a client with bipolar disorder who's not slept in 72 hours, obviously, that is also concerning, but not the major concern. So that can wait. All right, so the answer would be D. All right, next question. And I'm going to throw in drugs in here as well, because they do like to focus on drugs quite a lot, especially for psych. Okay, a client taking clozapine reports sore throat and fatigue. Which should the nurse take? Select all that apply. And clozapine, you guys, what kind of class of medications does clozapine fall under? Looking at the endings of this drug.
Schizophrenia.
This is schizophrenia, so this is falling in the antipsychotic class of medications. Okay, so antipsychotic, and just to kind of give you guys a quick breakdown so you get able to better answer the question, there are two types of antipsychotic drugs. One is the typical antipsychotics, and then the other one is the atypical antipsychotics. So when you have antipsychotics, the typical ones are considered first generation. Okay, and the second generation is the atypical ones. Always remember the first gen is always like the typical parents. The second generation is the atypical parents, okay? So in here, Halidol, okay, the most common one that you might have very heard of is first gen, and chlorpromazine, so zine ending. Okay, chlorpromazine ending is also first generation. Second generation endings are a little different. Done, Prazole, and Pitine, okay, quetiapine, which is also known as Seroquel. All right. Now, the biggest things that you're watching out, especially for the first gen, is that they have these things called EPS, extrapyramidal side effects. And this is the major thing that you need to remember about antipsychotics. Extrapyramidal side effects are expected side effects, FYI. So if you see these on a question, they are not something that you're going to call the doctor for because they are expected. EPS. So what are those expected side effects? You're going to have what they call tardive dyskinesias, which is usually more in the face and the mouth, where they're going to be doing, oh, sorry, I didn't realize my camera's not on. So they're going to be doing tongue thrusting. So they might be doing that repeatedly with their tongue. They're going to have eye blinking and they're going to have tremors. Okay. And this is normal for these patients. Okay. Now they might also have ataxia, which is difficulty with gait, with walking. And they might have dystonia, which are involuntary movements. So they're going to have like twitching. Okay. They're going to be also very restless. Sit in a doctor's office. And if this patient is walking, getting up, walking around, sitting down, getting up, walking around, very restless, all EPS symptoms. Okay. The other symptoms that you're going to have is agranulocytosis, which is referring to low white blood cell count. If my white blood cell count is low because of the side effect of this medication, I am at increased risk of infection. Now, when you look at the second generation antipsychotics like risperidone, aripiprazole, Seroquel, these ones also have EPS symptoms, but they are much less. That is why they are what they call more improved. Think about the iPhone, the more improved version. Okay, so they have less EPS symptoms, but they also then again tend to have agranulocytosis. And second generation, they are gaining a lot more weight and they have development of diabetes risk. So we do monitor blood sugar for our second generation ones. Right? Knowing that much information about this, I'm going to go ahead, let you go back to the question. Okay, client taking clozapine, and clozapine, do you guys remember what kind of, is it going to be, we didn't mention clozapine on there, but maybe we're looking at the ending. Is clozapine a first generation or second generation? It's going to be a second generation drug. Okay, so it's an atypical antipsychotic. Okay, so based on that, what do we do? So would we notify the provider? What do we think? Am I going to notify the provider? Remember that we mentioned agranulocytosis.
Yes.
So low white blood cell count. So yes, I am going to notify the provider because they have the risk of agranulocytosis and they're actively having symptoms of sore throat and fatigue, which would tell me that they're probably getting some sort of infection. So yes, I would notify the provider about that because that tells me that the medication is causing them to have a weakened immune system. So I do want to let the doctor know. Okay, would I check the white blood cell count?
Yes.
Yes, absolutely. Okay. Would I reassure this is a common side effect?
No.
No, it's an adverse reaction. Okay. Would I hold the medication?
If the we won't know about the white blood cell if it's low. If it's low, yes.
So we don't know yet, but so I
yeah,
would
this
hold
is
the
what
medication.
I'm saying. We don't know.
We don't know yet. So yes, you would definitely hold the medication until further evaluation. Yep. And educate client to continue medication. So no, Because they're actively having an adverse reaction, we would not. So the answers would be A, B, and D. Okay, it's a pretty tricky question, I think, with the wording as well. So this is one of the reasons why you want to know that sore throat and fatigue, the weakened immune system. So anytime it says weakened immune system, you want to try to do all the things that are related to not further causing weakened immune system. And because that weakened immune system then, especially the white blood cell, and why, and again, this is a concern because why is it such a big concern? Because remember, their actual white blood cell count is very low, which means that their immune system is not able to fight any infection, and you don't want it to get worse and worse and worse, because then they're going to be very immunocompromised. All right. Okay, next question is going to be, okay, this is a therapeutic communication questions. I know a lot of students miss this because just the wording sometimes. Okay, so you guys can take a look at this question. Okay, if you know the answer, you can say it out loud.
B.
B, tell me more about your feeling, okay? And this is a big hint for anybody that has trouble with psych questions. You want to really choose a statement that allows them the opportunity to talk. So most likely it is going to be answers like, okay, let me know more information about that. Tell me more about how you're feeling. Okay, so those things, they're open-ended statements. Okay, they allow the patient to express what they are feeling. And most likely that is the correct answer in many situations. Okay, tell me more. Give me some more information, okay, about how you're doing, how you're feeling. So B would be the correct answer. Okay, next question is, okay, this is about a manic client, and trust me, you will see lots of them in real life. A manic client is intrusive and touching other clients. The nurse should ignore the behavior, tell the client to stop immediately, calmly redirect, and set clear behavioral limits. D, place the client in restraints. Which one?
I'll go for C.
Calmly redirect and set clear limits. Yes, mania clients, very important to have consistent structure, clear boundaries, and you are calmly communication. Restraints, are they the first resort or the last resort?
Last.
Last resort, always. Okay. All right. This is a typical question related to medications. And this one, you definitely need to know the syndrome. This one and serotonin syndrome is a must know. Okay. Which findings suggest neuroleptic malignant syndrome? And on top of this question, I want you to also tell me what drug can contribute to neuroleptic malignant syndrome. What class of medications?
Can you repeat the question again?
Yeah, which class of medications is
First
neuroleptic malignant?
generation antipsychotics.
Actually, for both, but for both class. So yes, very good. So this neuroleptic malignant syndrome is a major complication related to your antipsychotic medications, which we mentioned. We mentioned the Halidol, the chlorpromazine, the risperidone, the quetiapine, the aripiprazole. Okay, remember, guys, those drugs, especially if they're taken long term, they can lead to something called neuroleptic malignant syndrome. So what are there's really three things that stick out with your NMS. What are the symptoms that you would find?
High fever, muscle rigidity.
Yep, high fever, okay, muscle rigidity, severe muscle rigidity. And then what else? So there's a couple of other things that stick out here too. Diaphoresis and altered level of consciousness. And you would not see bradycardia, everything would go up. You would see tachycardia. Okay. And so high fever, muscle rigidity, tachycardia would be common, not bradycardia, diaphoresis, and altered level. But you definitely need to know severe muscle rigidity and high fever. And there's a specific drug that they give also to treat the muscle rigidity, because what muscle are you scared is going to become rigid? What muscle, if it becomes really rigid, is going to be life-threatening?
Lung.
Not the lung. Lung's not a muscle. The diaphragm.
Diaphragm. There you
The
go.
diaphragm. Yeah. Okay. And remember, severe muscle rigidity, you're going to give them a medication called dantrolene, which is going to reverse. It's a reversal agent. Dantrolene is the name. So you need to remember that. Okay. Dantrolene is a reversal agent. So complication of antipsychotics, NMS. Okay. You're going to have severe muscle rigidity, high fever. Give them dantrolene to reverse the muscle rigidity, so we don't end up, losing our diaphragm and die because of that. All right. Okay. Which meal choice? Oh, let me copy the answer here. Which meal choice indicates understanding of MAOI teaching? MAOI teaching, guys. We know this.
Tyramine.
Yes. You want foods that have low tyramine.
Mm-hmm.
Okay. You want to avoid foods that contain a lot of tyramine. So which one would be the best choice here?
Fresh
cheddar. No.
Yeah,
Beef.
aged cheese contains
Cheddar.
tyramine.
Beef.
Alcohol contains tyramine. Fermented foods contain tyramine. So kimchi, sauerkraut, all these. Okay, even chocolate has some tyramine in it. Okay, cured meats, no. So B would be the correct answer. Fresh grilled chicken and veggies would be that. All right, and pepperoni, of course, is cured meat, so no. Okay, and talk about MAOI drugs, because they might not say MAOI. They might give you the name of a drug. What are some examples of MAOI drugs that you guys remember? MAOI drugs. Selegiline. Okay, isocarb.
Azilect, I don't remember the generic name, but it's Azilect. It starts with a Rosaglins, something like that.
Yeah, you're thinking about
Nardeal.
Nardo, which is
name.
phenelazine.
Yeah, the
Phenelazine.
generic name.
It's interesting how you remember it by the brand.
Yes,
name,
the
right?
brand name. This is how
Yeah.
I know for you guys is the generic.
Yeah.
If I
That's
see
good,
the
that's
generic, it
good.
would be easier for me to remember
The brand names. Yeah, I can tell. But ladies, I would recommend you remember these three drugs mostly. Okay, the selegiline, okay, isocarboxacid, and phenelazine. Okay, these are probably the more likely ones that are going to come on there. Now there are some other ones like transcyclopramine, parnate is another one, but really these ones I would remember. You remember. Okay. All right. And then what happens if they have tyramine containing foods? What happens? They go into what if they eat a lot of tyramine containing foods?
hypertensive.
Hypertensive crisis. Okay, so that worst complication is going to be hypertensive crisis. Blood pressure is going to shoot up. Okay, so we want to prevent that, obviously. Very good. Okay. Okay. So this is an anxiety condition related. Okay, client is experiencing a panic attack and is hyperventilating and trembling. What is the best initial action for this patient? Best, and the key word there, ladies, is initial. Initial.
Action.
So what would you say?
I'll still go for C.
C, stay with the client and speak calmly, of course. Remember this, C, yep. So remember, this is not the time to educate them. Would you want to be educated when you're panicked and hyperventilated, or is anything getting to get to your brain? No. Okay, so remember, this is also looking at our A, B, C, D, E. Remember, we talked about A, B, C, D, F, E. Okay, we take care of feelings first before we educate. So if they're anxious, we deal with that, and then education comes last at that point. So C. Okay, if they're hyperventilating also. Let's just add on to that. If they are hyperventilating, they're having a panic attack and trembling, what kind of a metabolic or respiratory acidosis or alkalosis can they go into? Which one?
Alkalosis.
Respiratory alkalosis, because they're breathing off the CO2. Very good. Good. All right. I'm going to give you guys a lot of medications related because from my NCLEX students that have taken it, they did tell me that there is a fair bit of questions in psych related to meds. So I would highly prioritize. Guys, also, I would focus on lithium. So I want you to maybe write that down. Lithium is a high priority drug that I would focus on for sure. Just like digoxin is a high priority drug that you want to know everything about. Lithium, I would focus on heavily too. Okay. All right. Next one, I'm going to give you a question actually on lithium specifically. So a client taking lithium presents with vomiting, coarse tremors, slurred speech, and confusion. Lithium level is 1.9. And of course, they will give you guys the normal values, and I'm just going to give it to you. So therapeutic range for lithium is 0.6 to 1.2. That is a therapeutic range.
B.
B, hold lithium and notify provider. Yes, this person is going into toxicity, and you can see that they're having a lot of neurological symptoms as well. Very good. All right. I'm going to try to figure out if you guys, and this is another question. I'm going to try to see if you remember what kind of condition that they're in, plus the answer to the question too. Okay. Oh, actually, the question is related to that. Okay, so we have a client taking sertraline, develops agitation, hyperthermia, clonus, and diaphoresis.
A.
Not A. Look at the medication. Is sertraline a antipsychotic? No, sertraline is.
SSRIs.
Yes. So this is going to be. It's SSRIs.
What's B?
B. Serotonin syndrome. Okay. Remember sertraline, and I know a lady out there who knows all the trade names, is Zoloft. Okay. So this is Zoloft, sertraline. There's really 3 drugs that I need you to remember for SSRIs, which is going to be sertraline is one of them. The other ones are escitalopram, which is known as Lexapro. Okay, again, don't really need the trade names unless it helps you remember it that way. Escitalopram. And there's one more, which is fluoxetine. Okay, so exetine endings, pram endings, and troline endings. These are the 3 big major SSRIs you most likely see. Okay, and remember, this is serotonin syndrome, which is a complication of SSRIs. Remember, serotonin syndrome, you can see with any drug that affects the serotonin level, which is what SSRIs do, and serotonin, remember, is a neurotransmitter in your brain. You will not see serotonin syndrome with antipsychotics. You will only see NMS, okay? You will see serotonin syndrome if you're taking a drug that affects the serotonin level, such as also MAOIs. You are also likely to see serotonin syndrome. MAOIs as well, because MAOIs affect the serotonin level on top of affecting the dopamine and the norepinephrine level. Would you see serotonin syndrome with SNRI drugs? SNRI. Would you see serotonin syndrome? Think about it. SNRIs, do they affect the serotonin level? Yes, they do. Okay, so you'll see that the examples of SNRI drugs, it's kind of hard, but duloxetine is the very common one to remember. I know that it has the same endings, but remember SNRIs, not too much of a difference. The only difference is that SNRIs affect 2 neurotransmitters, serotonin and norepinephrine. SSRIs only affect the serotonin level. Another example of SNRIs that you can remember is venlafaxine. Really, these 2. Okay, these 2. Okay, so I'm going to kind of narrow down on what drugs you need to remember for these classes. Okay. And with serotonin syndrome, remember, everything goes up. You're going to have, number 1, altered mental status. Body temperature is going to shoot up. Okay, you're going to sweat. Okay. What is clonus, by the way? What does clonus mean? What is clonus? Switching. Okay, oftentimes you'll see clonus when they're talking about seizure activity, which is also something that you could have with serotonin syndrome, but they're going to have this kind of random twitch, involuntary rhythmic muscular contractions. So that's clonus, right? And they're very likely to have that. All right. Next one is going to be okay. Which labs the nurse monitor for a client taking valproic acid? And I want you to also tell me, what is valproic acid given for? There's
Seizures.
2 reasons.
Seizures.
And what's more the psych-related reason? It's considered to be a mood stabilizer. What condition do you need your mood stabilized? Tricky question. Anybody know? Think about all the
They use it on bipolar patient.
Excellent. Bipolar patients. Yes. So 2 reasons, bipolar and seizure. So what would you monitor for this patient? And this is going off of basic information. Know that a lot of your drugs affect both the kidney and
Is it
the liver.
Select? Oh, it's Select all that apply.
So
No,
they
I
affect-
didn't see if it was a Select all that apply.
Oh, okay. It is a select all. Yep.
Yeah, A will be one of them.
Absolutely. It can be hepatotoxic, so you'd monitor liver function tests. Can you tell me some names of some liver function tests, please? Anybody?
AST.
ALT and alkaline phosphatase. Okay. What else?
What about speaking of the liver, what about bilirubin? Since it's
Yes, you can monitor the bilirubin too. Yep, I would add that on there. But when they say liver function tests, they're specifically talking more so the AST, ALT.
oh, okay.
But bilirubin can be part of it. Yeah, sure.
Yeah.
I'll give you the bilirubin. Why not?
Okay, thank you.
Okay, what else would you monitor?
Platelet.
Platelet counts, yes, because valproic acid does what?
It make you can boost easily.
Yeah,
Bleed easily.
thrombocytopenic, okay,
Okay.
which is low platelets, very good. Okay, what else?
What about no, ammonia is not part of it.
You would,
Oh,
because
I would also,
remember,
yeah, because it's liver, yeah. I was thinking
Yes.
about lipase, the stuff. I don't know.
Yeah, good rationale. You're thinking about the liver, okay? If your liver is affected, the ammonia level is going to be altered. Because remember, ammonia is a byproduct of, ammonia is a byproduct of protein metabolism, and ammonia is supposed to be processed by your liver. If my liver is impaired, it's not working, I cannot convert that ammonia into urea. Remember, the urea stuff is what's taken out from your body by your kidneys. So if my ammonia cannot be converted, it's mostly my liver that I'm thinking, okay? So ammonia levels are going to build up. So answers are A, B, and D, okay? So that tells you that the valproic acid is very heavy on the liver. So it affects the liver function, okay? So always make your associations there, liver function. Okay, and it's also thrombocytopenic also because of the fact that it's affecting the liver, because the liver also processes your platelets. So if you have issues with the liver, you're going to have issues with platelet production and also clotting factors. So you're more likely to bleed out. Right. Next question. All right, and this is going to be talking about amitriptyline. And so first of all, you guys will tell me, what is amitriptyline given for? Number 1. What is amitriptyline given for?
It's for TCA, tricycline antidepressant.
Exactly. TCA, tricyclic antidepressant. I'll give you a mnemonic to remember this. Amy tripped over her tricycle in the desert to remember the symptoms.
Wow.
Tripped over her tricycle in the desert. Okay, because this drug is primarily an anticholinergic drug. Okay, and if we have not encountered anticholinergic specifically yet, if any drug is anticholinergic, remember it's gonna be dry is how we say it. It's gonna dry you out. So based on that, what symptoms can you have, and possibly some symptoms of toxicity as well? You
A,
might possibly have A,
dry
dry
mouth.
mouth. Yep.
And you're gonna have urinary retention,
Very good.
and you might had you have some vision. I don't know if it's dilated
Mm.
pupil.
Yep.
Yeah.
You're gonna have some vision issues for sure.
Yes.
Dilated pupils. Yep.
Mm-hmm.
Yep. And very good, actually. That's really good. We're probably going to see also hyperthermia. So if it's going to dry you out, oftentimes when you become super dry, any situation, your body temperature just goes up, because remember, water has more of a cooling effect. So if you're super dry, your body temperature oftentimes goes up. So the answer is A, B, C, and E. Okay, let's talk about the mnemonic here. Amy tripped over her tricycle in the desert. Amy tripped is referring to amitriptyline. Okay, over her tricyclic is talking about the fact that this is a tricyclic antidepressant in the desert. Remember, if I'm stuck in the desert, what symptoms am I going to have? I'm going to have
Yeah, dry mouth. Yeah, everything will
dry
be
mouth.
dry.
Okay, remember the sun is so hot, and it's getting into my eyes, so I'm going to have some vision issues. Okay, I'm probably also going to be things like constipated, because I don't have anything to eat except for cactus in the desert. So constipation is another one. I'm not drinking a lot of water, okay, or I'm retaining a lot of urine and I'm not peeing out. So low urine output, urinary retention, okay, and I'm probably going to be sweating out a lot, diaphoresis, okay. But that's the opposite. That's the only symptom that's not anticholinergic. Okay, everything else is pretty much anticholinergic, which means everything is very dry. Right? So A, B, C, and E would be the correct answers for this one. Right. Okay, next one is related to this medication, and you're going to tell me what class of medications this falls under. Okay, which client should not receive lorazepam? What kind of drug is lorazepam?
On anxiety medication.
But what class?
Benzo.
Benzo. This is a benzodiazepine drugs, okay? So which client should not receive lorazepam? Who should not get lorazepam on this situation?
C.
Oh,
B is actually correct. Yes, very good. Okay. So, guys, acute alcohol withdrawal. If patients going through acute alcohol withdrawal, do they have symptoms of anxiety? Yes. Okay, so we do give them a lorazepam or the benzodiazepines to treat them. If a client is having panic disorder, they're very anxious, of course, I'm going to use lorazepam. If the client has pre-procedure for anxiety, yes, very common to receive a sedative such as lorazepam, diazepam, alprazolam, whatever it might be, okay? And C, client with myasthenia. Remember, we don't give it to our patients with myasthenia gravis because benzodiazepines will depress the muscle tone. Remember, patients with myasthenia gravis, remember we talked about this, I think, last time, is that if they have myasthenia gravis, they're already at risk for weaker muscles. So you don't want to further weaken it, okay? Because myasthenia gravis, remember, is a condition where you have issues with the neuromuscular junction, the muscle and the nerve connection, okay, is damaged. So you do not want to give them benzos because of that. So C would be the correct answer. Okay. Can I use benzodiazepines for treating seizures, acute seizures?
Yes.
Yes, very good. And am I going to give that intramuscularly or IV? If they're having an acute seizure, would I give intramuscular or IV?
I think IV.
Actually, intramuscular.
Mm.
Yeah, because you have to think about a lot of different things. If somebody's having a seizure, do you think it would be appropriate for me to sit there, hold them down, and try to insert an IV? No.
Makes sense.
Intramuscular would be it's going to be a little bit slower than IV, but it's going to be the most efficient way to get to them. Okay, I am. Okay. Oh, I'm sorry, this question got cut off. This is asking about ziprasidone for ziprasidone. Oops, sidone. Okay, which nurse monitors for which serious adverse effects for ziprosidone? And what medication is ziprosidone, by the way?
I don't know.
Look at the endings, guys.
Yeah, I see the dome.
Yeah, what other medication did we talk about today that have the don't endings? Starts with it's
Risperdal.
risperidone. Very good, risperidone. So that falls under the what category of drugs? Risperidone falls under
Psych.
antipsychotics.
Yes.
Okay. And this is a very specific condition that this one can go. So it's a one answer. And again, if you guys get questions like this where you have no idea what the drug is and what it does, I always want you to look at the answer choices. And this is another key tip. You want to look at the answer choices and you want to say which one is going to kill me fast, which one is serious, airway, breathing, circulation related. So based on that, what would you say on this?
QT prolonged.
QT prolongation. Very good. Okay. QT prolongation, remember if that PQRST, remember the QRS is ventricular action. Okay. And the T wave is the ventricular reset. If that becomes prolonged, see vidance. So it's taking my heart like really long to contract. I'm going to go into a condition called torsades de pointes, which is a very serious heart rhythm. Okay. Anytime you hear torsades de pointes, very, very serious. So the answer is going to be B, QT prolongation. So that's a tip that you can remember. No idea what the drug is. Always go ahead and take your best choice in regards to airway, breathing, circulation. Because weight gain is not going to kill them. Okay, hypoglycemia, yes, could potentially kill them if it's really low, potentially. But renal failure, again, acute renal failure and chronic renal failure, not going to kill them right away. You know that, right? So QT prolongation would be your best guess. All right, let's finish off with one last drug, and then we will continue with psych because I think there's a couple of things that we could probably continue working on. All right, so which client should avoid bupropion? And what is bupropion given for? It's a multi-use drug as well. And it's a lady who remembers the trade names. Do you remember what the trade name is for this one?
It's used for
Depression?
depression.
So it can be used for depression, okay? It's multi-use. What other uses?
I remember.
So it's used for smoking cessation
Oh no.
as well. So it reduces craving, okay? It can also be used for ADHD when you don't want to use stimulants, okay? But majorly used for three things I'll give you is it's used for MDD, major depressive disorder, okay? It's used for smoking cessation. And
seasonal
it's
affective disorder.
very good. Seasonal effect, excellent. Seasonal affective disorder, and of course, ADHD, and that's a off-label use ADHD, really. Okay, but any of these. So the answer would be which one based on what I just told you. So in which one would you avoid bupropion? C, because the other ones you would give, right? So you would avoid bupropion in patients that have seizure disorders because bupropion lowers the seizure threshold. If some drug lowers a seizure threshold, that means that it's going to make it more likely. So if seizure threshold is lowered, it makes it, so think about it, it makes it more likely that they're going to have a seizure. Seizure threshold is increased, it's going to be harder for them to reach that level, so it's less likely that they'll have a seizure. And remember, bupropion, we do give it for MDD. So A is right. We do give it for smoking cessation, yes. And we do give it for seasonal affective disorder. So the answer is going to be C based on that. All right. Okay. Ladies, let's come to a stop right here.
Because
Yeah.
I didn't even realize it was 7.
Yeah. Yeah. Time flies when you're having fun. No, I'm just kidding.
It's very fun tonight.
So we will meet back up on Monday, and I think we probably still need to review a couple of major things on psych, so we'll continue on.
Yes, please.
Okay.
Because I heard Psych is very big on NCLEX.
Yes, yes, it is. Yes, especially the drug. So I think your guys' homework assignment maybe is to review some of that stuff before we meet.
Well, okay, I have a question. I don't know. Did you send the Psych slide? Because I'm having issue with my email.
Oh, I sent the NCLEX. I sent another one with the NCLEX RN one, but I can send the Psych one over to you guys right now too.
Yes,
Psych
please,
one's
thank
like
you.
split into multiple. Let me just send it to you because I have a really bad habit of forgetting and then.
You're not the only one.
So let me just send it to you. Let me see if everybody's on here. So 1, 2, 3, 4, 5. Yep. So I'll send this over. And this is just Psych Schizo. I have some other Psych slides that I will also send over to you guys right now.
Yeah, thank you.
You're welcome. All right, ladies,
Thank
I will
you.
send. Yep, no problem. I'll see you guys on Monday then.
Monday. Thank you. Have a
Review-
nice weekend.
No problem. And review all the Psych stuff, please, before.
Yes, we will. Thank
Okay.
you.
Excellent. Bye bye. Good night.
Bye.
Good
Good
weekend.
night.
Bye.
Thank
Bye.
you. You too. Bye.